Recording now. All right, you should be good to go. You're on mute, Jeff.
Okay, can you hear me now? I'm on audio on a different line.
Yep, we can hear you.
Perfect. Hi, everybody. Thank you for coming in and happy 2021. We are happy to do this Sustainability Affinity Group, and I will go to the next slide if you don't mind, Heather. Per a little bit of entertainment as we wait for folks to come in, this is our travel photo of the day. I believe this is Rich's personal osprey friend from Cape Cod feeding its young, which if you look are in the nest. And going to the next slide. So today we're going to do some announcements. First, we're going to spend the day talking about tiering and some of the relationship of tiering to value-based purchasing. And what we're doing today, which I'm really excited about, is we are going to have everybody participate in a polling, a survey online as we're doing this. And then we're also have a great panel here from Philadelphia, Florida, and Orange County. So we're really appreciative to those folks who we'll introduce a little bit later. And then since we are here today between Martin Luther King and a very auspicious inauguration, we wanted to spend a little time as a community reflecting on the events that are beyond our own world. So we hope you'll indulge us and stick around to the end for that as well. Heather, if you want to go ahead and do your announcements and we'll get going.
Yes, thank you. So just a reminder, the Sustainability Affinity Group is also eligible to offer continuing education credits. We can offer those to social workers, RNs, NPs, MDs, and PAs. The process will be the same as that we're doing in the Academy. So you'll be sent out the Google Doc attendance sheet where you will put your information, including your email address. You'll then complete the course evaluation, and then you will receive an email from the Boston Children's CME department with an additional survey to complete, and then you will be given your certificate. I am sharing my screen now, so I'm going to share these links in the chat at the end, and I will also email them out as well, so you'll definitely get them. If for some reason you have any issues or any questions, feel free to send me an email. And my next announcement, I want to encourage everybody to please rename yourself to include your state abbreviations in front of your name. This will help us all know where everyone's from, and this is going to be very important for the Academy session. So just getting everyone into the practice of having their state abbreviation first. So you'll look at yourself. If you hit participant list and you find yourself, you should be able to click on yourself and click rename. And then if you put your initials of your state first, and then you can do underscore or just put your name after. That we'll be able to easily identify you from your state. If you have any questions about that, let us know. All right, Jeff, I'll hand it back over to you.
Great. Thanks. It's good to see people still coming in and to see where people are from, because that actually helps, I think, us learn what team you're on. So we're going to spend our time talking about tiering today and patient identification. And this is the fourth of our Sustainability Affinity groups. I think I mentioned earlier that we're hoping to continue these for sure through the end of the fiscal year, which is June, and hopefully beyond that as well. I want to go back and just talk about tiering in relationship to sustainability and payment models, so we're all on the same page. And this is a little bit of review from stuff we did, but it'll just take a couple minutes. Just to remind folks that when we think about payments, we think about fee-for-service models, which I think everybody knows the most about. You send the bill, you get a feedback. Capitation, which is what we heard from Gil Liu and the Nationwide folks about a global capitation. And that's at the provider level. And then some mix, which could be a per member per month for complex patients, and fee-for-service as well. Value-based purchasing, by definition, is payment that is tied to some outcome measure. And I think value-based purchasing can be a little bit, where you get a you get a little pat on the head for improving your immunization rate or something like that, or it can be a much more global thing as well. I guess I will just say this. I was listening to a podcast from Health Affairs, and I was a little disappointed that they said they're not sure how much mileage we're going to get out of value-based purchasing overall. And I think that was an interesting commentary, but I think it really comes down to something that we've talked a lot about here is what are we measuring as results? The other thing I wanted to say about payment models, so I think it's really important, is that these models, these 3 or 4 things that are in the top, apply differently depending on whether you're an insurance company, a provider organization, or an actual provider. So insurance companies get capitation from Medicaid so that they take on risk for the state. Administrative services provider, which could be an insurance company in a state like Connecticut, for example, they don't take on any risk, but they do the administrative services. The risk goes back to the state. Provider organizations do value-based purchasing or negotiate for services with the managed care organizations. And I would venture to say that most of you who are in big organizations, if you have a value-based purchasing type contract, you don't see it directly in your own world, and you as a provider are getting paid by the RVUs you generate, and maybe given some time for complexity. So I want to put that out there just so we are on the same page as far as those things are concerned. And then I want to just go to the next slide and talk about one other thing that we reviewed, I think, on the second SAG, and these are the components of accountable care models and value-based purchasing that need to exist to make them work. And they are defining the population, defining what services are being included, and that could be things like is dental included or is mental health included, stratifying patient complexity, measuring care, and then determining payment for services, avoided cost, incentives. We're going to talk today really about the first and the third of these, the defining the population we're serving and stratifying patients for complexity. Next slide. In defining patients, we can define them based on medical diagnoses and medical complexity. So one patient with asthma may not be the same as another patient with asthma. And we can define based on social service involvement and social risk. And we're going to leave that third category for another SAG session. It's really super important, but I think I would definitely say it's more nascent in its development. I also want to just remind everybody here who's a provider, who works in a provider organization, or people who are not and work in managed care organizations, that all of this relies on the appropriate coding or the appropriate putting of diagnoses into charts by the people, the clinicians who are actually seeing patients. So I just think that that's, we sometimes think that because we rely on a coding algorithm, but that coding algorithm ultimately always relies on the medical diagnoses. Alrighty, next slide. I'm not going to spend too much time on these, but I think it's really important to make a point here that medical complexity algorithms are for children with medical complexity are complex and imperfect. And I want to make that point because I think we tend to think that unless we get this perfect, we can't ask for payment or funding or know who to coordinate care for, and that's just not true. And I think we'll get to that a lot with the panel today, but I just want to make the point because I think it's super important that people don't beat themselves up because they don't have the perfect system in mind. And with that, I'm going to tell you about two imperfect systems briefly. So if you can go to the next slide. This is the system that is used for complexity for adults and children. It's run by 3M, and I can never figure out why the guys who make sandpaper and a whole lot of other chemicals out of Maplewood, Minnesota, which I drove through for decades, somehow did a clinical risk grouping, but they did. so anyway, and I just want to point out that these are the top 5 risk groups that they have, and they are the ones that were used in an article that I've quoted a fair amount by David Bergman on proving value for care coordination and learning collaboratives. But if you go from the bottom, a single dominant lifelong chronic disease, and then you go all the way up to catastrophic conditions, you'll see that these categories aim to collect all of the most significant risk patients. And they do an imperfect but not a bad job of it. The 2 other risk groupings that people talk about are CDPS, which is the chronic disease payment system, which is the one that's free and has been run for free, and that's why it's often used. And then the ACGs are run out of a group that's related to Johns Hopkins. So this is the one, and just to tell you that it's imperfect, and we'll talk on the next slides about why they're imperfect. And then the next one is if you go to the next slide, Heather, this is way too complex, but this is a group that was funded by AHRQ. Minnesota was one of the 2 states that helped provide information for this. But this is a system that Rita Mangione-Smith and Tamara Simon created to identify kids who were categorized in 3 categories: complex chronic disease, non-complex chronic disease, and then non-chronic disease. So really briefly, kids with complex chronic disease had 2 or more body systems involved in a chronic condition. And then the second bullet really says that chronic condition was going to last at least a year. And then they gave a bunch of categories for chronic conditions, and including these body systems. And then also talked about a progressive condition that was associated with decreasing health and decreased life expectancy, and then technology dependency. So you see already in this that in order to do a finer capture of complex chronic disease, they needed to go beyond just the diagnoses and look at things like technology dependency, or things like the length of time that the disease would occur. And I bring this up because just so you have a little understanding of it. The next slide talks about the other 2 categories, or the other next category, which is non-complex chronic disease. And those are conditions that were going to last a year, that were intermittent, but actually always had to be addressed. Diabetes, asthma, depression, attention deficit were these. And the next slide is the last category. There are children without chronic disease, and those are, the common things that are episodic. I really want to just say about these that we can look at these different categories. And as I said it before, I want to say it again, they're not perfect. But I think what we're faced with when we're talking about looking at sustainability is we need to all agree, from Medicaid to the payers to the hospital systems to the provider teams, what constitutes kids we can actually serve and should serve with the extra benefit of care coordination. And so I bring these up because they're the best we have, and not because they're perfect, but because we know that any of these systems are fraught with some challenges. And I really want to bring them up also because I want to encourage all of us, as we have the discussion that we're going to have now, to not to hook on to something of these that we can use, either these or just a dichotomous, this child gets care coordination and this child doesn't, but to make sure that we don't get hung up too much on the precision, but kind of know that we have to agree on all the levels of our system about how to do that. So if we'll go to the next slide, just to get back around to some of the payment stuff. This is what we have started with, and what I've learned as I've been listening to you folks and your teams in the Care Coordination Academy, and having some separate conversations with some of the teams. These are some of the ways people are thinking about how to get paid for this. It includes enhanced fee-for-service billing. Can you code for more things, or can you get an increased rate for your billing? Do you get a per member per month for patients of a certain complexity? Does an organization like the managed care organization or Medicaid give you some sort of a grant? So this is, as we've said all along with the SAG, an all teach, all learn kind of event. So we're hoping that we'll move on to that now. And then last slide, just to say that we'll spend more time in future SAGs on identification and tiering for social risk. I'm really, and I think a lot of us are really interested in doing this and making sure that this gets included. As I said before, it's new. And then some tiering and risk stratification around more complex value-based purchasing models. But I don't want to, the reason we separated out the second of those is because we don't want to make this, we can tell you about a lot of complex systems, and we have already a little bit with some of the stuff that was going on in Ohio, but we really want to make it so that we make sure that everybody has an on-ramp for figuring out how to approach and have the conversation around care coordination and payment for that. So with that, I think I'm going to turn this over to talk about the panelists here a little bit. And I'm very excited that we have asked, cajoled, agreed to have the folks from these three organizations to be panelists. And what we're going to do is we're going to ask a series of poll questions. And then Rich and I are going to ask the group to reflect on the poll questions, and then how they have done these things so far. And then we really hope that you'll chime in either with your own voices or via the chat, so we can hear about your own help and your own challenges around this. Our goal here today, to be honest, is to get people to understand how to identify patients in a prospective sort of way that you can then go and ask and talk to your payers about. And our first discussion frame will really be around tiering and patient identification, and then the second will be around your relationship to the people who are deciding how much time and resource you have around that. Delighted to have with us Karen Pugh, the Director of Case Management and Social Services for Children's Hospital of Orange County, and Ann Carpinelli, the Medical Director of Quality and Care Management. From Philadelphia, we're delighted to have Katie McNilly Kaplan, my mom's maiden name, Director of Innovations, Grants and Innovations. And from Florida, we're delighted to have Camilla Da Silva in Care Coordination at Orlando Health. So thank you all. I will wave to you all, and we'll keep going here. We can go to the next slide then. I'm going to turn this over to Heather to just do the slides, and we'll have, I think, 4 questions first, and then we'll have our first discussion.
Yes, thank you. So we're going to do this in form of poll. So you'll see the question here first, and then I'm going to launch the poll. So we're just asking you what your role is on your team. You'll be given a couple option choices. Just a moment. Launch it now. Should be up on your screen for you to select. Give everybody about 30 seconds, and then we'll review the answers. All right, we got 5 more seconds. All right, I'm going to end, and we'll share the results. Can everyone see that? You see it, Jeff? Looks
Yep.
like we have a good amount of team members, which is great. We have a really good distribution, family representatives. We have Medicaid and payer reps here, Title V reps, team leads, and team admins. Excellent. All right. Our next question is, how do you identify patients that need care coordination? Do you do it by a set of diagnoses, by a standardized tool, by consensus and informal agreement of staff? I'm going to launch this as a poll. Just a moment. Okay, you should be able to put your answers in now. This is looking interesting so far, almost exactly equal of all three.
That'll be a great discussion.
Yeah, all right, I'm going to share these results. There we go. So a lot of people doing consensus and informal agreement of staff. Then we also have standardized tool and a set of diagnoses. I'm sure if I made this multiple selection option, it could be all of the above as well, or a couple of them.
It's kind of good, though. I think we asked you guys to pick the most prominent mechanism, I guess I would say.
Yes. All right.
Okay.
Keep going, guys. We have a couple more questions for you. Thank you for staying engaged. Okay, so if you do use a tool, is it homegrown, made within your own institution, or do you use a national tool? Let me launch this one for you. Okay, go ahead. All right, a few more seconds. Okay, and lots of homegrown. Some national too, but a lot of homegrown. All right,
We have
and
one more question here. Is that right?
yep, one more question before discussion. Okay, so our last question before our discussion comes up is, for your process, do you include social risk factors?
And I confess that I needed to know how you were doing this because it's been so relevant, even though, again, we're not going to do too much on, we didn't do too much on this before, though it may come up in the discussion.
All right, I'm gonna share these results now. I'm liking these answers, lots of yes.
Oh, great. So it will be interesting to hear about that in the discussion. Cool.
All right, I'm gonna send it back to you, Jeff. Thanks, guys.
Great. I'm going to share the discussion moderation with Rich. Rich, are you out there?
I am.
Cool. So if we can, I'd love to go in maybe in order from Chuck to and down the line, and just to ask the folks who are talking to maybe just talk a little bit about how they're doing identifying kids in their own systems for care coordination. So it would be great if we could go ahead with the and ask the folks on the panel to talk about that, and we'll also ask them the two other questions that follow, and that's you know, do you identify that if you use a tool or diagnoses, and what kind of tool, and who does the work of this is the other part of it. So if I could ask you guys to do that, if I could ask the Children's Hospital Orange County folks maybe to go first.
Sure. Hi, guys. I'm Annie Carpinelli, Medical Director for Quality and Care Management. Can you hear me okay?
Yep.
Okay. It's insanely windy here right now, so if you can't hear me for some reason, let me know. And Karen, you're on too, right? You're just not on my strip of photos right now?
Yes, and I'm here.
Okay, good. So our system is pretty unique in that we have on the Chalk Hospital side, which is going to be more CoIIN, we have a model for assessing risk. Oh, now I see it, Karen. Thank you. And then on the other side, we have Chalk Health Alliance, which is more in my purview, which is looking solely at Medi-Cal. So only at the kids that have Medicaid in California that we're taking care of within the Chalk system. And that includes the hospital itself and the Chalk Pediatric Network. So basically anybody who has Chalk in their name or affiliation. So I will just speak to Chalk Health Alliance first. I heard someone say recently, once you've seen one state Medicaid program, you've seen one state Medicaid program, and California is pretty complicated. We in Orange County are one of only 6 that use something called a county operating health system. And that basically means that on the county level, we have the plan, the health plan called CalOptima, and under that there are 13 health networks. We at Chalk Health Alliance are the only pediatric one. And we're unique in that all of our Chalk Health Alliance employees are actually Chalk employees, have Chalk email, access to the EHR that Chalk uses, and most importantly to us, have relationships with people who work on a clinical level with our patients. So that's different from all the other health networks. So we were able to help make the health needs assessment that on the county level CalOptima requires us to use for care coordination. We were able to help make it more pediatric friendly because they were using a lot of questions that were more adult centric. But they definitely do incorporate social determinants for sure. They ask things like, is the family overwhelmed, and what kind of resources do they have access to, like CalFresh, which is essentially food stamps, what kind of therapies they have, were they recommended to get services that they don't feel like they have access to, what kind of social supports do they have. There's screens for domestic violence, there's screens for tobacco use and illicit drug use for kids that are 12 and up. And essentially on the CalOptima level, they have this health needs assessment that they do with new members that qualify. So basically there are 2 programs, seniors and persons with disabilities. So for us, it's the kids with disabilities, largely autism and Down syndrome, a lot of behavioral things. And then on the other side, we have the whole child model, which are kids that have high complexity, mainly, it could be various things, but a lot of them are the ones that you would would come to mind automatically for care coordination. Kids that have trachs and vents and G tubes and medical complexity in terms of chronic conditions. So basically they screen on the CalOptima level with a survey that is usually done by phone, but can also be done by mail. And it has about 22 different questions that the family answers. And then based on that, they use an algorithm that we're not especially privy to. It just says medical management system when I looked it up. But they put it in this system. It basically gives a medical complexity level, and then a nurse at CalOptima reviews it, decides if he or she agrees with that. Maybe we'll change it, maybe not. There are 3 different levels. And if we are assigned a child that has the top 2 levels, one of the top 2 levels, then we have a meeting for that family, an interdisciplinary care team meeting. And that's when our patient care coordinators get involved and build rapport with the families. And we have this meeting, we invite people from Chalk, their primary care providers, specialists, people from regional center, which is basically early intervention here. And then we have a meeting for them and continue services. We don't discharge them. So we're there for them if they need us. For the bottom level, for the basics, we reach out by phone, but we don't necessarily have a meeting. unless we find that there's something going on that would necessitate a meeting. So that's the quick and dirty on our system. I don't know if anyone has any questions before you have Karen talk more about the hospital side of things using our EHR.
Anne, can I ask you about, just to be clear, there are 3 levels. Does everybody get into one of those levels, or are there kids who have no chronic illness who are in a level 0, for example?
So to qualify for seniors and persons with disabilities or whole child model, you have to meet it by diagnostic criteria. We do have another program that some of you are probably familiar with called Health Homes. And that is based on diagnosis and number of ED visits or number of admissions or risk for homelessness. So that often captures our kids with other things like mainly asthma or behavioral health issues. So if a child has like major depression or asthma, it wouldn't qualify for one of the other 2 programs. We often capture them through the Health Homes program. And that we do our own health needs assessment, but it's essentially asking the same sorts of questions. And we determine the complexity level with our own nurses. And then we also have another program that we're piloting with United Healthcare on the commercial side. And we're using an algorithm that United has. They give us a list every month based on complexity level, and we kind of filter it and look in our system to see if it is a patient that would really necessitate care coordination. Because sometimes they look like they might be complex, and then you get into the details and you're like, actually, they're doing quite well, and they don't really need as much as you know, the algorithm ends up spitting out.
Yeah, cool. Let's just do this. I think we're going to let Karen talk about the hospital side. Hi, Karen. And then maybe we'll just ask clarifying questions first, and then, because I want to make sure we get to everybody, and then we'll have sort of the discussion questions after that, if that's okay with everybody. So Karen, you are on the inpatient side?
I actually am the director for case management and social services across the continuum. So one thing that's unique about our system is that we have case managers and social workers that report all to one system. Pretty unique, and because most of the time, case managers on the inpatient side and social workers on the inpatient side report to one person, and then on the outpatient side, they report to someone else. But the beauty of our system is that we're able to hand off for that continuity of the patients. So on the inpatient side, CHOC took a data-driven approach to classify patients who were most at risk for readmissions using a statistical and machine learning algorithm. So we identified risk factors of readmission. We looked at things from the literature, of course. Demographics and socioeconomic status of patients were in most of the models that we saw or that we used. Resource utilization, so whether the patient had been admitted and readmitted or not. We used the pediatric Rothman index and the disease severity, and of course, the diagnosis as well. So we were able to, using that in the machine, it does its magic, and then it spills out patients that are high risk, moderate risk, or low risk for being readmitted. That information is on our patient's EMR. So each patient's chart shows, and if you hover over it in the EMR, it shows you exactly where the patient is, if they're high risk for being readmitted, moderate or low risk. The predicted probability for the high risk was greater than 0.22. Moderate risk was 0.11 and 0.22. And then low risk was less than 0.11, and which tells you that we really had a really good handle on the probabilities that we were looking for. So once we, so the case managers and the social workers are able to this when they log into the EMR. Anyone in the organization is really, but we look at it and decide what we're going to do for the patient. I see my case managers and my social workers as the bow ties. And so we are based on an assessment done by the case managers who go in and talk to the families. So what we found was that in the past, in just using the tool that was inside of our Cerner documentation system, the case managers were just looking at what the providers were saying the reason was that the patient was coming back in. But once we took that assessment and really had them go in and ask the family, why did you come back? You know, were you comfortable with the care that was designated for you when you were discharged? Were you prepared? Did you feel prepared? Were you able to get your medications? Once we were able to do that assessment, then we were able to find out the real reason, what really brought the family back to the organization. The social workers are doing a social determinants of health assessment, and we really have gone more live with it now, with them all looking at the reasons, the socioeconomic reasons why the patients came back. So both assessments, one by the social worker and one by the case managers, then we're able to decide what is it that the family needs? What kind of support do we need to provide them? Who do we need to reach out to in our system? Is it pharmacy that needs to provide some education about medications? Is it the nurse that needs to really talk about, go into more depth about the care that needs to be provided? Who, if the family was not prepared or they didn't feel comfortable, how can we help this family so that they're not being readmitted back into the system again? So I'll stop right there because that's how we stratified our patients on the inpatient side.
Wow. That is great. I'm going to ask if there are any clarifying questions anybody wants to either add to the chat, or else when we get to the discussion, I think we'll look at what you guys did. It's really impressive to hear. So thank you.
I think our boss is chatting. If he wants to use his voice, he certainly is welcome.
You guys are doing great. You're doing great.
Jeff, this is Richard. I'd like to raise a question, and it may go into the Florida presentation as well, but Karen and Annie, that was really, really great. I'm trying to figure out, so first of all, Karen, it's really exciting that you've actually got a unified approach from inpatient to outpatient. The number of places, the delivery system side, that consider those two separate universes is agonizing. So however you guys pulled that off, that's great. And that could be a comment that at some point I would like to share as a best practice and how that could get done. But the other piece of this is as follows. I'm mindful, Annie, in particular on your side, that you're essentially handed lists from the payers. And those lists, one of the first things you said you do is you look at the list to say, yeah, that kid really fits and really doesn't. So here's my question. Are we able to take a look at the payers as one component of identifying these kids so that the delivery systems can basically receive them? Or is it a both? In other words, do delivery systems need to have a methodologic approach, and that the payers need to have a methodologic approach, and that there's some sort of a reconciliation that happens? And is that a best practice?
Yeah, and Dr. Weiss, feel free to chip in too, but if we're talking about the CalOptima side, we are essentially required to go ahead with the assignment in terms of care management level and decide about having the interdisciplinary care team meeting based on what they send us, mainly because they give us payment per member per month so that we can pay our patient care coordinators. That's part of it. But also, we generally do find something that the families do need in that process, even if it's not obvious. So there's a lot of transportation needs or connections to social service resources that we find through the meetings. And the families just like knowing that they have support. So even though it might look like on paper they don't need things, we usually do uncover something that we can help with. As far as the United program, we do have say in whether we feel like somebody does not need care coordination services. So if I look at a patient that they sent over who has, a history of, something that has since resolved, they were a 32-weeker who had multiple procedures done, but now you read their well child visits and it's essentially they're doing great and they don't need anything. And we have the liberty of saying that we're not going to do care coordination for those particular patients. One last thing is CalOptima does receive our interpretation of what the care management level should be after our care team meetings. So they do look at that. And so when it comes in on an annual basis, they do factor that in as to whether or not they're going to make it a higher level or not. I hope that makes sense.
No, it's perfect, because essentially what you just said, and I wanted to bring out for everybody listening in the SAG, there is no single platform that does this well. And does it perfectly. And I love the fact that you guys are tracking correlations. You have the ability, at least with certain collaborators, to do something that feels transactional and is based on experience. And I think this approach has opportunity for scalability. Michael Weiss, would you like to jump in?
Yeah, just one comment I'd like to add, which I think would be a good learning for the group, depending upon where you are in this journey, is remember that most insurers, most health plans are very adult-centric. And so their stratification, their models, their leveling of patients is not necessarily as well informed in the pediatric world. So we find that we have to engage them up front to really help them to understand some of the nuances of pediatric care. So for instance, with CalOptima, the program Dr. Carpinelli was describing, we rewrote the health risk assessment with them and got it approved by the state because they were asking questions like, do you feed yourself? And if it came back no, it was a risk factor. Well, the kid might be 4 months old, right? So there were many examples like that. And additionally, things that were missed that we needed to add. So I would just throw out the caveat that you need to work with your payers to make your programs pediatric centric.
Wonderful.
This is Heather. There's just 2 questions from the chat if we have a moment. Jeff, do you want to do some questions now, or how would you like to organize this?
I'm just looking at the questions for 1 second.
Sure.
I think that let's do this. I want to make sure we have time because other people have prepared and have a lot to say from Florida and Philadelphia. So if we can go to Camilla from Orlando, and then we'll go to Katie from Philadelphia, and then I think we'll go back and circle around these questions. So
Sure.
I think I'd like to do it that way if that's okay.
That sounds great.
Camilla, you out there?
Yes, I'm here. Can you hear me?
Yes.
All right.
Thank you so much.
Oh, great. So just to give you a little bit of context, our program started no more than 9 months ago. Our program was born from our pediatric residency clinic that was providing essentially primary care to any patient that didn't have a place to go. They did have a large number of patients with high medical complexity, all kinds of diagnoses. Our hospital also has a program called Tiny Babies. So we have plenty of those very much less than 25-weeker babies being discharged to the pediatric residency program. So we started kind of like absorbing those patients that the clinic, the residency clinic, was identifying as being too much for them. All pretty much the large majority based on diagnosis, but a good number of patients just with severe social situations, compliance, follow-up, so all of that kind of stuff that was hard for them just to have a good grip on it. So we started just getting those patients in and then looking and seeing like, how can we work like tiering up? How do we apply our limited resources We're still on a hiring phase. We're still building our team. So everything is very much scarce. So we started to partner with our Medicaid providers in the area and started to find out that they actually have already done a lot of work in that sense, that we were just like not aware or not seeing perhaps the benefits from the provider side. One of our Medicaid managed care plan here in Florida is called WellCare Stay Well. They do have an algorithm that they follow. Essentially, patients qualify for like the highest level of care coordination from the plan. They have to be receiving private duty nursing, so home health care, or be in some kind of prescribed pediatric daycare. Those are the ones at the top of the list. Of course, they are the most costly patients for the insurance, having like 24 hours nursing at home. Not all of them are necessarily like trach invented or with a lot of technologies. Some are. So we started to looking at those lists and started comparing to the patients that we have and noticed that there's a lot of overlap, of course, but there were some patients that we were considering high risk. They were not, just because they were not receiving certain services. And we are still in that like brainstorming phase, like how can we better define that, which patients we believe are on the top of our list. So we went back to basics, created an Excel spreadsheet, started throwing a lot of information in, collected all the demographic information for our patients. We collected diagnosis, gestational age. We looked at which payers were they, like Medicaid, dual coverage, transitioning from Medicaid to Medicaid waiver because they're approaching 21, looking at all kinds of different problems. And we settled for few diagnoses, so a few buckets that we could, before that we were getting a lot of patients in that category. And we started looking also at our zip codes. Florida, one of the Greater Orlando zip codes is already known for having, for being like more affected with social determinants of health. So we knew that that specific area, patients in that specific area might need an additional level of care coordination. Now, putting a little bit of also covering our eyes a little bit in terms of like social problems, because like you guys mentioned, it's just like another beast altogether. So for now, since we are so new and starting to look at things from the beginning, we're like, let's focus on patients by diagnosis, not forgetting that those zip codes, those social determinants of health are still there, but trying to tackle one big problem at a time. So we noticed that we have a large number of patients who are either spina bifida, cerebral palsy, Down syndrome, and categorizing them. And from there, if they have have other comorbidities, or if they have on top of the diagnosis, the social component, we bump them to the top of the list. Aside from that, we have partnered with our palliative care team from our inpatient side, and we crossed our list with their list and found out that we have about 60 patients now that we share that have some kind of life-limiting condition and are being followed by our pediatric palliative care team. We started to partner with them and working a little bit more closely, and they became our eyes at the hospital. So every time when one of our palliative care patients get admitted to the hospital, they are the ones helping us provide like the warm handoff for care coordination, helping us with other social aspects of like difficult discharges, and creating that partnership has been really important for our team. So trying to allocate resources in places that we wouldn't think of before. So they're also on our like tier 1 at the moment, and that list keeps evolving. It keeps changing a little bit more. Patients are being added, and we have been looking at those very closely. So we're using now a tool that was developed locally. We have tried to look at this tool and see if there anybody else in the nation has used, and we have not found any sources. So we believe this tool was developed locally, and it helps us screen patients at least every year to see if new things have been, if things have been changing, or how do we prioritize maybe a little bit differently. It's called the pediatric faces. It also includes some of the social determinants of health that we specifically question specifically directly to housing and food insecurity, their legal status. So trying to use those to advocate for additional resources for our patients. So using that combination of looking at the diagnosis, looking at utilization a little less, but more in terms of palliative care involvement, and our local tool to help us understand a little better our panel of patients.
Thank you so much. Hey, could you just say the tool you called pediatric what?
What do you mean? Our
The name
pediatric
of-
faces? The tool?
Yeah.
Yeah, faces.
It was,
FACES,
okay.
yes.
Oh, great. Okay. And then I just want to ask one other clarifying question, and then if there's other clarifying questions, we'll take them. If not, we'll I think we'll ask Katie from Philadelphia to go next. When you develop this tool, and when you are more like when you review the diagnoses and the input from palliative care, do you do it in the provider team, or are there folks from Medicaid or one of the Medicaid managed care organizations there with you?
So we have several different approaches. Right now, the patients that we share with our palliative care team, we review with them weekly. We have carved out a little bit of time to sit down with the palliative care team and go over the patients, especially those who have had a touch point either at the hospital or in the outpatient clinic and have some to-dos. So we prioritize those patients, also look at those that we are worried about, those that you just have a feeling something might be going on. And we have been very keen to, and very aware of our, we think that something might be going on either from our side or palliative care side, and try to pay attention to those patients. There is always the little flag that goes up. Aside from that, we have monthly meetings with our managed care provider, payer, and we review the patients that have care gaps and are within their with a certain level of complexity from the insurance side. So patients who are receiving home health, private duty nursing, or some kind of medical daycare, we review those patients with them monthly. Internally, we review our patients weekly and as often and as possible. It's a little bit more challenging but we try to go on a certain diagnosis on a certain days to make sure that we continue to review them periodically and not miss anything.
Great. Excellent. I just want to honor Nick Claxton from Philadelphia made an important point, which I think is sort of the crux of some of this, is that medical complexity and need for coordination don't always line up, and social complexity is obviously important. I will give a nod to Nick and everybody else that I naively thought we were going to try to separate those, and that's my bad, and I appreciate both you, Camilla, and the folks at CHOC correcting that. I want to move on to Katie because she has to hop off a little bit early, I think, but we still have hopefully have plenty of time for her to talk about how they are addressing this in the Philadelphia team.
Hi, everybody. So I'll tell you that we are very in the early planning stages of our integrated care for kids pilot with St. Christopher's Hospital. So Renee Turchi is our key partner in this. We had the unique opportunity where community behavioral health is, Pennsylvania is a carve-out state, so we're the behavioral health managed care organization for all of Philadelphia County, which one of the unique advantages of that is it gives us access to all the behavioral health data for the whole county because of integrated care initiatives, also all the physical health data for the whole county. And then because we're quasi-governmental and our board of directors is the Department of Behavioral Health in Philly, we also have very strong partnerships and relationships with city departments, including child welfare. So we haven't actually operationalized a formal tiering strategy for this. We had mapped out a vision. We had applied to the CMS and we're not awarded, but we plugged away regardless. And for that, I think I talked in one of the last larger meetings that the tiering was really going to be focused on the kids at risk for removal from the home, and that those kids were really going to be identified at the top tier, including kids with juvenile justice, kids in psychiatric residential treatment facilities. And then as you worked your way down to the bottom, it was ideally surveillance of kids who are hopefully well when they come in for well visits. So Pennsylvania's Office of Mental Health has recently required pilot proposals for what they're calling community-based care management programs. And so we submitted a proposal, which we actually just found out was very well received by the state. I don't know what their changes are, but where they're requiring that we do pilots, and we submitted an integrated care for kids pilot with St. Chris. And so, like I said, we're in the early stages. Some of the things that we've done thus far is identified the screening tool. So we have a work group that's been working on that. And so we're going to use the Arizona self-sufficiency matrix because it's easy to use, pretty easy to understand, it's flexible. So we are going to tailor it to some of the needs that we think are missing from the current tool. Our care navigators are going to be peer level positions. So either community health workers, certified peer specialists from the behavioral health side, or in Pennsylvania, we now have family peer specialists. So family members with lived experiences becoming a Medicaid reimbursable service in Pennsylvania. So the care navigators would be a peer person that would meet with the family, do the screening, and then circle back around referrals needed. So we still have to work on all the operational workflows and also figure out how we would incorporate a tiering strategy into all this. There's 2 clinics. My Philly team can just chime in at any point. There's two clinics at St. Chris that we're targeting. So that first question, the identifying need, Heather, you were right. Like if you could choose all the above, I would say all of the above, right? So I think in the one clinic, it's for children with special needs. So obviously the kids in that clinic all have various diagnoses, often medical complexities. And then the other clinic is the Center for the Urban Child, which is our main pediatric clinic. It's a high volume. And in both cases, though, we'd be trying to catch kids coming in for well visits is our current goal. And so we still have some work to do to figure out, you know, how we identify which families we even screen. So that's still in planning. And based on the state's, you know, pilot, we're supposed to be launching this in Q2 of 2021. So we have a lot of work to do between now and April. So I'm excited we at least have a tool picked and some thoughts around the staffing makeup. The staffing will also include CBH's clinical care managers who will be co-located on site. So Dr. Turchi already has some experience with this, where CBH has, in partnership with Keystone, pushed in a clinical care manager from CBH that provide some on-site support around referrals within the CBH Behavioral Health Network, as well as connections to other city departments where CBH may have strong relationships. So let me think what else is key. Yeah, so really, I mean, at this point, we have to, you know, some of these questions we were talking earlier, Dr. Williams and I, about you know, just concretely thinking, how are we going to operationalize a lot of this vision? The other exciting thing I'll say about the state's request, it's almost like shocking that we're being asked to do this because it's exactly what we should be doing. So sometimes it feels surprising, is that we were required to identify community-based organizations that we would contract with to address the social determinants of health. So one of the reasons we selected the Arizona is because it captures both behavioral health needs. I forget if it captured behavioral health and physical health needs of the parent, the caregiver as well, but we're going to definitely be making sure that we're doing an intergenerational approach, but also that it captures the social determinants. And we're going to be expanding some of the existing partnerships that St. Chris has. So they have a medical legal partnership. So we'll be expanding to include a paralegal and an on-site attorney that can address things like domestic violence, that can address issues around SSI, public utilities, any array of issues that legal consultation or even representation could be beneficial. There'll be on-site educational advocacy. So the exciting thing is that we can actually use Medicaid to pay for addressing some of these social determinants of health. And the plan is in this pilot year, we'll be better understanding the cost to develop a case rate to ideally, it's unclear what the state's long-term sustainability plan is, but our initial thought with an INC model was to flip it to a value-based arrangement. And so, our financial folks are involved in all of this as we figure out what this costs to do. So I don't know if I covered all the questions or if my Philly colleagues have something I missed.
Katie, I had a clarifying question about your work with, because you are sort of quasi-governmental.
Mm-hmm.
Do you have kids you're identifying separate from the screener because of their past diagnoses or their past child welfare involvement? And maybe I missed that. Or, are there kids that are automatically defaulting into care coordination because without the Arizona self-sufficiency matrix sort of tool?
So no, it's a good question. And we have not discussed differences. And so I don't know whether Renee wants to chime in between how we would, right now we're talking about a broad approach where we would do the screener on everyone, because it would tell us, whether or not they need to be connected to some of the on-site. We're also going to have, I forgot to add that we were also going to push in on-site behavioral health services at St. Chris to provide a brief consultation and intervention. So ideally trying to catch these families while they're there, engage them, and then have the care coordinators maintain contact for families, help with any other warm handoffs that are offsite. So, right, the kids that are coming into the Center for Special Needs clearly already have diagnoses and medical complexities. And we have not, right now my assumption is we would still be completing the screener with those families. We've been having lots of conversations about just the way we would administer the screening tool, how we'd approach the parents. A lot of our family members have shared concerns about, being asked these kinds of personal questions. So just thinking, with the training and the types of protocols that we've put in place for those sorts of things. So, so to answer your question, we have not, we're still working on it, I would say.
Cool. Yeah, it seems like you've got a great group of people together to organize around this work. So
yeah, and the exciting thing is we have a lot of data. It's just the ability we have to think through, how we'd operationalize all that. And so we're not, like I said, we're not quite there. So I'm looking at Rich. So disability status to performance metrics is a stratification technique.
Do you want me to give you a little more context for that?
Yeah, yep.
So I don't mind full disclosure for everybody in the entire academy. Katie and Tamara reached out to me well before we even thought about having an academy, and they were part of the inspiration for putting the Care Coordination Academy together. So just calling that out. But you guys began with this notion of behavioral health and behavioral health integration. We are literally this month beginning the adult and child course set review for Medicaid course sets at the CMS level. And we're looking at existing measures and the possibility of new measures. And one of my colleagues told me that the adult psychiatry community across the United States is beginning to promote behavioral diagnoses, not just simply as a measure of comorbidity, but say if we're looking at a hypertension measure or an asthma measure, if you could look at the data and stratify by behavioral health diagnosis as well. So it's the race, ethnicity, language are part of the stratification, but I think that you guys are sitting on a potential gold mine because so many of your patients have behavioral health needs. So it isn't just simply a front end tiering, but it actually could be a back end performance stratification opportunity as well. So people like you and Dr. Turchi over at St. Chris's and every one of us that takes care of patients with special needs, including behavioral health comorbidities, that we don't get punished in value-based arrangements. But in fact, if you are depressed, your hypertension is less likely to be well controlled. So any thought about doing that kind of work on the performance end of your metrics?
I don't have any thoughts on it. Although I will say there is some interesting research that Penn has done for us that it looked at members with co-occurring asthma and co-occurring diabetes. They also did COPD and found that the members that were getting behavioral health services actually did better on like for kids with asthma on measures of ED visits, the appropriate inhaler or medication. For members with diabetes, they were, more likely to, whatever I forget the metrics for diabetes, the HEDIS metrics, but perform better on those metrics. And so it almost looked like their services through the behavioral health side was a protective factor in ensuring that they manage their physical health conditions better. So, which of course, being one of the few carve-out states, we have taken that on the road to the state and to others that are anti-carve-out to say, look at these results around behavioral health, CBH being a protective factor. So I'll let, I know, so Renee or Joan or some of the other folks in the CBH team might have thoughts to share. Not to put people on the spot.
So Katie, I just want to say one thing about the carve out that I think is important is that the reason it works is because you guys are sort of forced to work together, and it's not a carve out, okay, this is a better economic deal for behavioral health and this is a better economic deal for physical health. And I just got to tell you, in Washington at some of the meetings that I know Rich and I have been at and probably others, there's this big debate about accountability. Should the behavioral health folks be accountable for the diabetes? And you have advocates in Harrisburg that are strongly advocating for the fact that, yeah, you can be carved out, but you're still responsible to each other. So your articulation of that would, I'm sure, warm the hearts of our buddies in Harrisburg. Well, as well.
The state's prioritized more integrated care initiatives, which has allowed all the lawyers to figure out how to do the data sharing better. So when I first came to CBH 5 years ago, some of their new integrated care initiatives were a nightmare because it took the attorneys months on the data sharing piece. And we've gotten beyond all that. And our history in Philly is that mental health advocates actually, with people with lived experience, that created CBH, that demanded that the county take over. So, so there's like sort of a feel good story to protecting the carve out, I'd say, in Pennsylvania, which might be one of the reasons why we're one of the remaining carve out states.
Yep.
Jeff, is now an okay time to get to some of the earlier questions too?
Yeah, that would be great. And I think, folks, we're calling an audible because we have another set of discussion questions, which may just have to wait because this discussion is really rich. So we have about 10 minutes left in this. So feel free to do one of a couple things. If you want to type in a question, that's fine. If you want to raise your hand or talk, then if you would just type that you'd like to do that into the chat and we'll call on you. But go ahead.
Jeff, there's a couple of questions already in there. So thank you to all of our panelists. This discussion has been great. I think we didn't realize that we wouldn't have enough time for more questions, but this is really awesome. So our first question is from Kim Brown in Montana. This is for Karen at Chalk. She asked, were there any concerns from families about having to complete both the care coordination and the SDOH assessments, and with 2 different professionals?
I know we didn't have any concerns because it's really a part of their work. You know, the social workers are going in and they're doing an assessment, and that's what we found. And what we're trying to do now is hone in a little bit better. So we have an assessment for the social workers. They do that. They go in and assess every patient. But some of the pieces of that prepare tool is not included in what they assess the patient for currently. And so that's what we're trying to do. We're trying to marry both so that the assessment is done. And then the 5-minute assessment that we do for the case managers should have been going in to see the families anyway to find out really what brought them back into the organization, and not just going by what was documented in the medical record. And so they really should go in and talk with the families, find out how they were coping at home. And so that's why we came up with that 5-minute. It's really quick and straight to the point, you know, to really try to help figure out, you know, what the concerns were for the family when they went home. So also for our high and our moderate risk patients, we set up telehealth appointments like 7 to 14 days post-discharge. So and it's an option for them. We haven't made it mandatory yet. We know parents and families have varying degrees of technologies that they have at home. And so we offer to them a telehealth appointment, and it's just when they get back into their home environment and are more relaxed and comfortable, and they, you know, can relax a little bit, you know, and being in the hospital is really stressful. So did they hear what we said about the medications and how to draw it up, and, you know, what to give and when to give it and how to do this and how to do that? And so it's just a check-in point for my case manager and my social worker to just make sure that the family is really, you know, acclimating to what they're supposed to do when they get home. But no, we have not, they have not said anything about, you know, it being too much of an assessment.
Excellent. This is another question for you, Karen, from Adanique in Minnesota. She wants to know, have you seen a confirmation of patterns between what your system predicts as high risk for return and what the actual return rates are for aftercare?
So I would need my statistician here to talk about the tool more specifically, but we have it really honed in and honed down to it being very specific. He would have to give you this very specifics about the predictability, but just to have that, you know, 0.22. So there's a very small room for error. And it's all electronic. When we first started trying to risk stratify our patients for readmissions, the chair, who's Dr. Lusk, and I, we were trying to do it by hand. And then when the statistician came to us and he had this tool, we're like, oh my goodness, where have you been? I felt like I was far ahead of my time in trying to say, you know what, if we could just figure out, you know, why is this kid coming back? You know, is it the diagnosis? Is it all the medications? Is it the, you know, the equipment that he has? You know, what is it? You know, and then for him to come in and do it in the background and it just automatically spills out onto our EMR, it was like, oh. So yeah, we were very happy to have it.
Thank you.
Karen,
sorry, go ahead, Jeff.
Karen, can I just ask, the 0.22 you're talking about, that's the rate of admission for the high-risk kids? Or is that a statistical predictive number?
Yeah, that's a statistical predictive number, yes. Yeah. For the tool. Yeah. So we evaluated several times over time, kept going back and readjusting things. Like I said, I'd need him here to talk more of the statistics part of that. Yeah. But yeah, it's a really good tool. Yeah.
This is Adenike. I'm sorry. Maybe I didn't clarify my question. I think I was looking more so for what would determine the correlation between the two. Like if you, if the system predicts that someone was high risk and then you saw them come back, was there like a correlation of like, these are the things that actually bring them back, which make them high risk, or the system said that they're high risk and actually there were so many that didn't come back?
So the tool updates all the time. So it's looking at diagnoses, the patient being readmitted. It has a whole lot of things in it. I could share the tool with you if you want to see it. And let's see, you said if we expected the patient could come back, did they come back? Yes. So when we first started doing these assessments on the patients, our high risk patients, that's how we started. We started with the high risk patients first. because we felt like we could have an impact with those patients with them not being readmitted. But when we really got into it, because of some of the complex issues for those patients, they were going to come back because they just had complex issues. And so then we focused our attention on those patients that were at moderate risk for being readmitted, and were able to, with our team, to make an impact of, decreasing the readmission rate for those patients. But you're right, patients who have, complex issues, some of them are just going to come back because they're complex kids.
Thank you.
Did I ask you that time?
Yeah, you did. And I think that maybe my question might be a little in the weeds too, as just like, I wonder what the pattern would look like. What would bring them back? Does it show on paper? And that may not even be something that could show on paper to correlate, but were you right was the system right in its prediction that those people?
The system was right in its prediction. I can tell you that for sure. But like I said, I need my statistician here to talk more specifically about the specifics about the.
Karen, I'll just back you up a little more. So Louis is our statistician, so we call this the Louis tool. Louis looked retrospectively to make sure that the tool works. So he would look at a child from a few years ago and look at their subsequent readmissions and find out if the tool works. So it was used. It is used appropriately. We're hoping that going forward, it will remain successful. But he did definitely use it retroactively to show that it worked.
I'm really interested. It's great work. Thank you guys so much for sharing. I'm super stoked to hear that you're doing the work.
I can share with you the article that we wrote about it too, the statistical model for 7-day readmissions. I can send it to the group.
Karen, if you wanted to share that with me, and I'm happy to send it out. Thank you.
Sure.
I think this is an incredible conversation. So I just want to honor the fact that we sort of got to some of the issues of relationships to payers. And we really wanted to look at a diverse models of identifying kids, both in terms of who was identified and in terms of their level of development. Because I don't want this I think it's always interesting when people are really far along that we don't overwhelm folks and make it seem like it's not possible. I think it's really a matter of hopefully people have some ideas of where to start. There are also some other things that I just want to honor that came up. One was this last thing that Karen whetted our appetite about around the tool. And I always think that tools in machine learning are only as good as the algorithms that and the data that gets put into it. So we'd love to see that as well. And then I think some of the other things that came up, I just want to highlight is, and this was is sort of who does the assessment and how connected they are to the community and how those folks are trained as well. Because I thought this idea of using peer specialists out of Philadelphia was really wonderful as well. So we hope that this session gave folks some capacity to think about how they want to set up identification in their own systems and how they want to work with their payers around that as well. I think we're gonna close this off. We wanted to spend, if you could go to we're gonna skip ahead, I think, Heather, a couple slides to things we didn't get to. And then I just really wanted to, Rich and myself and Renee and Heather and sort of the team that gets together and talks about what we're going to talk about. We wanted to spend a little time honoring, as I said in the beginning, that we're in a day between Martin Luther King holiday, honoring Dr. King, and then also our inauguration. And we thought, I think a lot of us spend our time in this wheelhouse, but we also spend our time reading news feeds and trying to figure out where we fit into the whole world. So we thought we'd honor that by just giving a moment to talk about that. I wanted to go ahead and read a quote that, if you see me when I'm downstairs in my office, this is the quote that's behind me often. So you just go ahead and the next slide. Darkness cannot drive out darkness. Only light can do that. Hate cannot drive out hate. Only love can do that. So, and hoping that for our kids and for our community, we move ahead. We had I had the honor and privilege of asking a dear old friend who was on these SAG meetings, Debbie Harris from Family Voices in Minnesota, to come on, say a few words if she wants, and then to hopefully read something that we all found very apropos of the moment.
Thank you, Jeff. Hi, everyone. I know these have been challenging times for me. So many things have kind of multiplied into what sometimes seems like insurmountable stress. But I feel like I was on my way to a medical appointment today. And of course, I was all masked up and everything. And a song came on, and it was, my mother said something like that. My mother said there would be times like this. And I kind of changed it a little bit to, there would be days like this. And I kind of changed it in my mind to, there would be periods like this in history. There'd be periods like this in democracies. And so I think there's always a remnant. There's a remnant of people who are kind, people who have empathy, people who have intelligence, people who have a spirit for change. And that's what keeps us going forward. And so I'd like to read a poem called Continue, because where there is hope, we can continue. And it's by Miss Maya Angelou. Continue to be who and how you are, to astonish a mean world with your acts of kindness. Continue to allow humor to lighten the burden of your tender heart. Continue in a society dark with cruelty to let the people hear the grandeur of God in the pearls of your laughter. Continue to let your eloquence elevate the people to heights they had only imagined. Continue to remind the people that each is as good as the other and that no one is beneath nor above you. Continue to remember your own young years and look with favor upon the lost and the least and the lonely. Continue to put the mantle of your protection around the bodies of the young and defenseless. Continue to take the hand of the despised and diseased and walk proudly with them in the high street. Some might see you and be encouraged to do likewise. Continue to plant a public kiss of concern on the cheek of the sick and the aged and the infirm, and count that as a natural action to be expected. Continue to let gratitude be the pillow upon which you kneel to say your nightly prayer, and let faith be the bridge you build to overcome evil and welcome good. Continue to ignore no vision which comes to enlarge your range and increase your spirit. Continue to dare to love deeply and risk everything for the good thing. Continue to float happily in the sea of infinite substance, which set aside riches for you before you had a name. Continue, and by doing so, you and your work will be able to continue eternally.
Thank you. Dr. Antonelli.
We thought of today's session. We wanted to bring a lot of know-how about implementation of care coordination, the implementation of measurement, interprofessional education and performance. And remember, the way our academy has taken that is we've put the families right in the core of that interprofessional team. I'm not sure that I can add anything more profound than Maya Angelou and Debbie Harris. That was just a wonderfully touching rendition of that. But I do want to encourage all of us, anybody that's been serving children and youth with special health care needs for the decades that we have, continue actually is probably the single most dedicated thing that we do. Come to work every day and think about those families that need us. Come to work every day and think about how we can collectively make things better. So I think I want to thank you, Jeff Schiff, for allowing us to share a little bit of Maya Angelou's wisdom. And I hope that the folks that are attending the SAG today and more broadly the Academy, this is really important work. The next 4 years are going to be profoundly important. And I look forward to continuing this journey with the families, with advocates, and with folks that come to work every day thinking about making care better.
I just wanted to jump in and say thank you so much, Debbie. That was beautiful. I'm going to stop sharing my screen for a moment. I'll let Jeff finish up, but I'm going to share in the chat the attendance sheet and also the evaluation.
I just want to say thank you for this community that is doing great work for the children of our country, and it's an honor to be part of it. And I think we have our charge for a while. So stay in touch, stay healthy and safe. We wish you peace, and we wish all of us equity in the coming year, and it'll be a pleasure to continue to work with you all. God bless.
Thank you, everyone. I will share the links by email as well, but they're also in the chat for now, the attendance sheet and the evaluation. Thank you so much.